Good morning, dear colleagues, ladies and gentlemen. It's my pleasure to welcome you here in the European Parliament. And I would like first, thanks to the European Society of Radiology and the European Association of Nuclear Medicine for organizing this discussion and for bringing together leading experts from across Europe. It is a real pleasure to see so many of you here today, and I really appreciate your commitment and your willingness to contribute to today's agenda. Cardiovascular diseases are responsible for substantial human, social and economic burden, but they are also among the diseases for which prevention and early intervention can have the greatest impact. And this is very important. Why I'm saying this? Because this understanding guided our work on the report on EU strategy for cardiovascular health, which I had an honor to lead as a rapporteur. Throughout this process, one conclusion became clear. Europe must go beyond a model which is centered primarily on treating cardiovascular disease after clinical event occur. Instead, we need a health policy that places greater emphasis on prevention, on early detection, timely diagnosis, and personalized care. And this is where medical imaging becomes indispensable. Radiology and nuclear medicine, therefore, are not, simply supporting services within cardiovascular care. They are fundamental to clinical decision-making throughout the patient journey, from identifying disease before symptoms appear to guiding treatment choices, monitoring disease progression, and evaluating outcomes. Radiologists bring specialized expertise in selecting the most appropriate imaging modality, optimizing imaging protocols, ensuring image quality and patient safety, and providing accurate diagnostic interpretation. Nuclear medicine complements this by offering unique functional and molecular information, allowing clinicians to detect disease processes at an early stage, identify patients at greatest risk, and support increasingly personalized therapeutic decisions. And these capabilities are essential if Europe is to achieve the Save Heart Plan's objective of reducing premature cardiovascular mortality while delivering care that is more effective, more equitable, and more sustainable. I am truly happy that both the European Parliament's report and the European Commission's Save Heart Plan recognize this. And they both place innovation and early detection at the center of cardiovascular policy. Advanced imaging is a key component of the cardiovascular care transformation, but no single profession and no single institution can deliver this transformation alone. Close collaboration between cardiologists, radiologists, and nuclear medicine physicians will be essential to fully realize the ambitions of the Save Heart Plan. Implementation obviously also require sustained investment in infrastructure, in workforce development, innovation, research, data interoperability, and equitable access to advanced diagnostics across all member states. The multidisciplinary nature of today's program reflects exactly the approach we need. Bringing together all of you, cardiologists, radiologists, nuclear medicine specialists, policymakers, and patient representatives is essential if we are to translate European ambition into meaningful improvements in patient outcomes. And I hope that today's discussion will help strengthen this partnership and contribute to the successful implementation of the Safe Heart Plan across Europe. So thank you very much for coming, for your willingness to participate in today's important agenda. And I'm looking forward to hear all your position and intervention. Thank you so much. I am so glad that here is also my dear colleague, Vytenis Andriukaitis, who is here as my dear colleague, a member of the European Parliament, but he is also someone who really understands the matter. He is a cardiologist, but also he is former commissioner for health and food safety. So, and yeah, I must tell you also this, that yesterday he got so important award for a lifetime achievement. So Vytenis, congratulations from the bottom of my heart. I will give you the floor. Please, Vytenis.
Thank you so much, Romana. Thank you very much for the very warm words. Colleagues, you are my colleagues because I spent in my practice 23 years, finally finishing with cardiosurgery. I was cardiosurgeon in Lithuania. I know what does it mean about what we are just speaking concretely. And that's just Romana presented all topic, I couldn't agree more. I fully in line with Romana just said, because completely, completely through the point and through the substance, It is really excellent. I was very happy when I was commissioner of 2014, 2019, we met many times with different European associations, including European Society of Radiology, and of course also nuclear medicine, But I didn't succeed to present cardiovascular plan at that time. But we tried to do more, and we proposed to have a state of health in the EU country profiles. And in those profiles, we press very much to include statistics and to see a common picture and which dominant, challenge is in area of health. Of course, healthcare, cardiovascular diseases were on top and are on top. And just Romana mentioned about figures, we know very well what does it mean. And of course, also after, I was very happy that that situation was evolved, and as you know, after COVID pandemic, when COVID pandemic is just started, you know that Ursula von der Leyen, under pressure of European Parliament, coined new definition, European Health Union. Can you imagine? Because we're just speaking about images. Now you have in your hands definition, European Health Union. It's not simple word. And then if you ask me, what does it mean and how it looks like now today, I can tell you that when Ursula von der Leyen proposed to have European Health Union, we decided immediately to collect experts and to present what does it mean true European Health Union. And we proposed to have building blocks, keeping in mind two issues, keeping in mind the Lisbon Treaty, because Lisbon Treaty do not allow European Union to act in more active way because national competences are at member states level. It's treated healthcare and care is national competence. It's not true. It's a mistake of Lisbon Treaty. But then we proposed, look, if you have possibilities to develop the coin European Health Union, it means that we need to choose, first of all, cross-border healthcare threats which are enshrined in treaty and allow Europe to act. And as you know, first block was crisis preparedness and crisis management. HERA was established, and Ursula von der Leyen proposed first building block of European Health Union. It means pharmaceutical package, it means preparedness package, long-term care strategy, comprehensive approach of mental health, and Europe is beating cancer. Those four were called first building blocks. And we immediately proposed second building blocks. And those second building blocks we proposed to have, first of all, EU cardiovascular strategy. And then I was very happy because people elected me into parliament. I'm first time elected. I never was in the European Parliament. But then my colleagues decided to pass to me coordinator role in Sand Committee, and I took, opportunity to keep own initiative report on cardiovascular plan in our hands, and I pass it to very nice person, very prominent professor who knows very well situation, and Romana was a rapporteur on cardiovascular plan and our European Parliament own initiative report. And now we have in our hands such cardiovascular plan. Can you imagine? It's a very big tool to all of us. And please use it in your home work. Please send this message to your governments, to your universities, to understand that now we have excellent opportunity to build the second building blocks of European health. Why I'm speaking about second building block? Because imaging can allow us to build networks from Helsinki to Lisbon, to exchange images, to see how can we diagnose, what can we do at early stages, how can we develop common standards, how can we propose interoperability and interconnectivity between different centers, hospitals, society, universities, centers of excellence, and of course developing European health data space, data, standardized data, and of course to send images immediately from one country to another. If we can do it, it means that we will strengthen European Health Union as such. Why am I speaking about this fact? Because, when I was commissioner, some cardiologists proposed to me to establish pan-European pilot monitoring atrial fibrillation. You have very excellent devices now. Now you have used all issues in your pocket. You can have devices which can, check your cardiogram. And if something would happen, you are on the road, and those devices will send your image into some center, and center can consult you, diagnose, and tell, okay, stop driving because something will happen. Can you imagine how preventative it is? You know that now, at the moment, about 17 million people are on the roads. Drivers, they're always very affected by cardiovascular diseases, hypertension, and so on. It would be so important issue to have pan-European network which can communicate our detectors with, and of course with different centers. But we need to have capacities. We need to have money. We need to have financial programs. And it means that your idea about images goes in the same way. That's all I can tell you, that I am very happy. Congratulations. We need to do European safeguard plans and to see how it can, translate your efforts into practice.
Thank you. Thank you very much. You could have not settled the scene so nicely, and it's now my pleasure to introduce the president of ESR, Professor Prokop. Matthias, here you have the remote control. For the introductory remarks from the ESR.
Yeah, thank you very much for both of you for this introduction, because I think it showed very much what we need to do in Europe. As the president of ESR, it is important for me to give our support for this initiative, And personally, I've been involved with the European Beating Cancer Plan, and before that with the Nelson Lung Cancer Screening Study. And I remember very well patients that we saved from dying from lung cancer that would then only 2 years later die from cardiovascular disease. So in order to get the optimum health for our patients in Europe, or our population in Europe, because they're not yet patients, we have to be preventive and use our means cleverly. We have the 3 pillars of the Safe Hearts Plan, and I think that as imaging, we can contribute to all 3 of those, but we also can look at another thing, namely affordability and accessibility, because the amount of money we have available is, of course, limited. So the question is, how can we use what we have already there to the maximum advantage to get the best primary or secondary prevention? And I'll come to that in a moment. Now, if you look at the treatment part, treatment is nothing without a precise diagnosis. So having a good diagnosis by lab values, blood values, ECG, but also by imaging is crucial because it guides ultimately the treatment we want to get. And the multimodality approach here is an important one because none of us can do it all by themselves. Now, if you look at CT, CT is one of our workhorses, and this is a CT angiogram that nicely displays a lot of problems in this patient's coronary artery disease, gives us a very quick overview of what is going on. And imaging allows us to detect disease. Here, for example, a valvular leak in a patient who had an aortic valve implanted. And as you can see that there is blood streaming from the aortic root into the ventricle back. So surgery had failed and needs to be repeated. We can localize the problem here in the coronaries and ultimately guide treatment for these things. Imaging is really important for that. And it's a fast track to diagnosis and treatment decisions. I mentioned already accessibility, and the important part thereby is money. We have to make sure that we're not spending unnecessary amount of money and make sure that we are using our resources in a clever fashion, which means we have to use existing data to identify patients at risk. We have to make sure that we are discouraging self-referrals where we see situations that people are doing stuff that is unnecessary. We have to make sure that we get it the first time right. And for that, the diagnosis is a really important part because the costs usually occur not so much at the diagnostic part, but downstream in the treatment pathway. Now, another thing is, I mentioned that we have data there. And one of the interesting things is that imaging goes by. It detects cancers on cardiac CT exams, and it detects cardiac risk on lung cancer screening. And here's an example where we have an MRI of the heart, and what we see is a tumor in the abdomen. Could be malignant or not. It's a pheochromocytoma. In this situation, it turned out not to be a cancer, but you have malignant forms who could be. Now, if you only focus on the heart, you may lose the opportunity to see stuff that others can't. So here, there was a cancer outside the field of view. So it is important that we use the expertise that we have in our imaging field in radiology to really detect and get the synergies that is necessary. So the link between cardiac and the rest of the world is really important to get the biggest bang for the buck. Another thing is if you turn it around. I mentioned already the European Cancer Plan and the lung cancer screening. Every single lung cancer screening scan also includes the heart. It's in the middle of the chest. And we know that coronary calcium is a very strong predictor of cardiac adverse outcomes. Now, here's a nice study that shows that if you use statins in these patients with a moderate amount of coronary calcium, their cardiac risk can be massively improved. And the fun thing is we can not only do that for lung cancer screening, but basically on every chest CT that we have. Because every chest CT includes the heart, we get the same information there. So it's existing data that can help us make our population more healthy with a minimum extra effort. And then there's this other thing, secondary prevention. If you find something like this, a thrombus in the heart, chances are high that this patient will get a stroke. So finding that and treating it is an important part. So we have lots of stuff in our field that helps us prevent cardiovascular negative outcomes downstream by using existing data in a much more clever fashion. Now, on the other side, when it comes to affordability, it is sometimes also important to know that you're not doing something. Here's the example of, again, the calcium score. If the calcium score is 0, no calcium in the coronaries, this study showed that it makes no sense to give statins. The outcome for the patient is actually the same. Saves money, saves the adverse effects of this medication. So it goes two ways. We basically can use the information to guide our treatment or non-treatment or our prophylaxis in a clever fashion. So I think imaging is essential for the success of the EU Safe Hearts Plan, but it's also essential for linking it to other health initiatives like the European Health Union, and as the European Society of Radiology, and I'm pretty sure EANM, we're really happy to support that and work with you to make it a big success and have the maximum effect on our population.
Thank you. Thank you very much, Matthias. And let me join the congratulations of Matthias, both to the European Parliament and the European Commission for placing cardiovascular at the center of the healthcare agenda of Europe. This is really a milestone. We really support it. And also congratulate the member of the Parliament Public Health Committee for the voting last week, supporting the report responding to the Safe Heart Plan. That sent really a very impressive political message in view of the assembly voting next September. Thank you. So the very first message I have following up Matthias is that both our society are really here today to send a clear message. We are fully support the vision of the plan, but we are here today to help the implementation, which is, in our opinion, one still critical part. So here on your desk, you will find the 2 policy briefings, one for each of these associations. And they are basically collecting a clinical example that are underlining our imaging is improving the diagnostic certainty, supporting the personalized care pathway, and also contribute to more efficient and sustainable air care system, which is really a very important point. We know imaging is complex and is the way to bring personalized medicine. We know for cancer, and we are now in the phase that we also are exploiting more and more for cardiovascular. And the Safe Heart Plan is including personalized medicine as one of the key elements. And in this setting, multidisciplinary setting, I would like you to look at radiological and nuclear medicine imaging, not as an alternative, but as a complementary approach. And I will just drive you to a very simple example. It's a busy slide, but I don't want you to be worried. The first on the left is showing an imaging. In this case is myocardial perfusion, but it doesn't matter. So what we are doing, we are taking images, but those imaging are not remaining images. Those images are becoming numbers. Those numbers are quantifiable, and they are very strong predictors of a certain event. But those numbers are not interpreted in isolation. We are then comparing with standards for population, for example, the gender, the sex. But in future, by combining the data, as you properly mentioned, we can do for risk factor or for whatever other parameters we want. And then this is transforming imaging or biology, because imaging are describing biology, into a number that then is becoming a biomarkers, is becoming a personalized biomarkers of that patient. At that point, once that we have the biomarkers, we can go back to the patient, we can stratify back the risk and see how that risk in that individual patient is expressing the disease or predisposing to a certain disease. Now, this is very complex, but if I want to reassume it in a very simple motto, I can say that images become numbers. Those numbers become knowledge, and those knowledge, it becomes better care. And this better care is not just better medicine, which is already enough, it's also a better value for our health systems. So in the next slide, you see that implementation might be challenging. So we have an issue about technology, access, and we will discuss that during the roundtable. We have collaboration, because in this multidisciplinary framework, the collaboration is key, but also we have to take care of the workforce, because without a proper trained workforce, innovation is not reaching the patient, and that is what is our ultimate goal. So investing in education, training, and retention of our skilled workforce, in this case, imaging professional, is key, as is key investing in research and in innovation. You also find in the policy brief the 5 asks from our association. We will have time to get into that through the other questions, to the question and answer session, but please have a look, because I think that those 5 pillars, if we will really be able to transform them into action, then we will be able to implement and to bring to every European citizen the vision and the content of the cardiovascular safeguard plan. Thank you for your attention.
Thank you, Paola, for this excellent presentation. So now it is my turn. My name is Rodrigo Salgado. I'm here on behalf of the European Society of Radiology, and I'm also the current president of the European Society of Cardiovascular Radiology. So I would like to start my lecture by asking 2 questions: how to solve a clinical problem and how to detect disease early. And for that, I would like to start with 2 brothers who go to the cardiologist because they have been complaining of chest discomfort for some months. Brother number 1 says, well, my chest pain is not always there, sometimes, but not while riding a bike, so I should be fine, no? And then brother number 2 says, yes, of course, doctor, you are right, I should take better care of my weight, but our father died of a heart attack, so my spouse, who often sent us here, she would really like to have a checkup. So the cardiologist performs what he usually does, and after the standard of care examinations, he doesn't find an answer. So he still has these 2 middle-aged men with a father that died of a heart attack, and he's still not sure, well, does the pain of the discomfort from these patients come really from a coronary origin? Does it come from the heart, or does it come from somewhere else? Is there something going on or not? So is uncertain of the diagnosis and is looking for a way, how can I make my diagnosis more certain? Or how can I comfort these patients, telling them there's nothing really going on? Now, we used to have only one way of looking directly at the coronary arteries, and that was using an invasive angiography. And we still do that very often today for very good reason. But in patients that you are not sure, would you send every patient to an invasive procedure just to confirm that they have nothing? I think the risks are small, but there are still some risks. So maybe we should look for a better way to look directly at the coronary arteries to figure out, is there disease or not? And that we can deliver with computer tomography. So for man number 1, he was sent to the radiology department. He got his cardiac CT. CT took about 15 minutes, 20 minutes, and the patient was sent home. And he came back to his cardiologist, and the cardiologist said, well, you do have indeed a significant coronary artery stenosis. The diagnosis is not always that straightforward. So he was then referred for an invasive procedure where an intervention was followed. The patient got a stent. And since then, he has been symptoms-free since 10 years. So what did cardiac CT and radiology here contribute? We established a diagnosis that was one of the possibilities, but we confirmed the coronary artery disease, and this patient got treated and survived happily ever after. But for the other brother, well, we didn't find significant coronary and high degree stenosis, but we did find premature remarkable atherosclerotic disease. So these patients did not have a high degree stenosis, but it was indicative that he had more advanced coronary disease than he should have for his age. Meaning for these patients, no intervention was needed on the angiography side, but a more medicamentous intervention was needed to optimize his medical treatment. And since then, he has been symptom-free for 10 years. So two brothers, two different outcomes, but thanks to early detection and intervention, symptom-free for a decade. What have we learned? Because this is, of course, important. We have learned that radiology brings something to the table for the European Cardiovascular Health Plan, as shown also by the previous speaker, on several things, from prevention, over screening, over diagnosis, and ending in treatment, and of course, also in follow-up with CT and also with magnetic resonance. And I want to show you one piece of evidence that has been collected for the last decades. There have been many trials, but one of the most important trials is the Scott-Hart trial, which again, as in the example that I have given you, have shown scientifically that when you add CT to the standard of care follow-up of these patients with stable chest pain, it improves the certainty of the diagnosis, both in the positive and negative way. And this has been confirmed to improve the outcome of the patients even 10 years after the initial diagnosis. And what I really like about this study is that what do you need for that? You need a capable CT to perform coronary artery disease. I would say most of the CTs momently are. You need normal software. You need basic cardiac radiology knowledge, and that's all that you need for improve the diagnosis and the outcome of the patients. So the infrastructure is already in place. Nothing more is needed than just to implement it. And this is one of the reasons that the European Society of Cardiology in the recent guidelines established that cardiac CT is not longer a luxury, it is a necessity for improving patient outcome. And of course, radiology, this is our profession. This is what we do. We collaborate with everyone. And there is a close correlation with the functional impact of, for example, this other patient who has extensive atherosclerotic disease, but it is very difficult to diagnose the functional impact. Therefore, we cooperate with the partners from nuclear imaging, as you will see in the subsequent lecture. Looking at the future, what can we say? We can not only look for stenosis, but we can also show in patient number 2, look of the amount of atherosclerosis, which can be more advanced than we may think based on typical risk factors. So coronary calcium gives you the vascular age of the patient. And it means, for example, when you see here, when you have no calcium, but severe risk factors like obesity, hypertension, that you will do better than someone who has no risk factors, but high calcification. So the quantification of coronary calcium, which is very easy to do, really improves the risk stratification for that patient. So I would like to conclude my lecture by saying that a goal without a plan is just a wish. This is from this well-known French actor. And I think this is what we are all trying to achieve here today as we gather from different corners of Europe and from different disciplines. Because radiology is not only a technique, it is a whole community. We rely on national societies. We have a network of national societies across Europe. We have already the experience of lung cancer screening, and lung cancer screening also gives something that we can use for optimal detection in these high-risk patients for coronary artery disease. So the Safe Heart Plan is not only a radiology plan, it's an European plan, but imaging really plays a central role here. Cardiac radiology is something that we do for everyone, not for ourselves, not only for radiologists, but for the whole European community, and we stand firm next to our colleagues from the nuclear imaging department to help European cardiovascular health. Thank you very much.
Thank you, and thank you for inviting me. I will be giving the functional perspective to this talk today. I am Lars Christian Gormsen. I'm a clinical professor of nuclear medicine, and I will be showing you a lot of what we actually do in clinical practice on the side of the nuclear medicine. So I will briefly be discussing why we need functional imaging on top of what my esteemed colleague just showed you. I will show you some basics of how it works and give you a lot of examples and images of really what is the clinical impact of adding molecular imaging, functional imaging, nuclear medicine to radiology. So what radiology does really well, Professor Salgado just nicely showed us. You can do non-contrast CT in 30 seconds and get a really nice risk estimation of individual patients. If you add contrast, you can even see soft plaques in the coronary arteries, which may benefit from interventions such as stent procedures, revascularization, and alleviation of symptoms for the patients. If we use MRI, we can see edema in the myocardial wall, which could be a sign of inflammation and a risk of early death. So to conclude, radiology is really good at providing detailed into the millimeter information on calcifications and stenosis and edema. But do these anatomical features really have a functional impact as well? I'd like to pick up on the previous speaker again. This was the 65-year-old man you just showed. It's a contrast-enhanced CT. There are many changes in the coronary arteries here. There are plaques, there are calcifications. Does this really mean anything to the patient? Or does the heart still get enough blood to function properly? So what we want to look at really is the microvasculature. This is where the actual exchange of oxygen and energy substrate takes place. And how do we image that? And that's where hybrid functional imaging or molecular imaging and nuclear medicine really comes into play. The beauty of this is really you have a molecule that illustrates or serves as a marker of function. It could be water if you want to look at perfusion. It could be glucose if you want to look at energy substrates. And you label this with a radioactive isotope, meaning that you can actually trace this in tracer amounts. It's labeled with a radioactive isotope, meaning that you can give minute amounts of this tracer and it will still show up really nicely in PET-CT or a SPECT-CT, even though you really didn't give anything pharmaceutical doses. Point is then we can image these molecular changes over each organ as we choose. This is again a heart. We've done an MRI. There's edema of the myocardial wall. And when we add the functional information, in this case a glucose tracer, we can see that there's something metabolically important going on. These are white blood cells in a sarcoid granuloma, something that may cause sudden death in the patient. So it's really important to do the functional imaging. Otherwise, we just think this is edema. I mean, this is just fluid in the heart. So for some of the radio tracers that we use in nuclear cardiology, we can use, for instance, rubidium or water for perfusion. We can also use system-EB. For metabolism, we like to use a glucose tracer like FTG, amyloidosis. We can use DPD. We have all sorts of inflammation tracers as well. Actually, in our department, we have more than 20 radio tracers in clinical use, and we'll use probably half of them for cardiac imaging. So for some of the examples, I'd like to go back to the same problem we saw before. This is a CT with many calcified plaques and a possible stenosis in the LAD. The question is then, does this have an importance? And then we do the perfusion scan under stress conditions where we dilate the arteries to the max, and we can see that there's no perfusion in the anterior wall, meaning that the myocardium is suffering from ischemia. And then we can even quantify it if we have a PET scan and do a water PET. We have quantifiable perfusion. We have a threshold of 2.3, and we can say this is definitely something that's going to need intervention. And then we can send the patient to an invasive procedure, which may have some side effects. So we really like to choose the right patient. In this case, this was again seen in the same place, but there were problems in the perfusion scan. We can see the stenosis, and the patients had an angiography and a stenting, and there were really no symptoms at follow-up. So another example, a 67-year-old man with reduced cardiac function. Will he benefit from a bypass procedure? This is important. Do we really want to send the patient for a very invasive and burdensome procedure? So we need to see whether the area with reduced perfusion in the lateral wall, in this case, still is alive. And then we use a tracer that first see the reduced perfusion, and then a second tracer to see whether there's still energy consumption in that area to show that it's viable. In this case, we could see there's viable myocardium, and bypass surgery was performed. By contrast, in this case, a 78-year-old woman, also with reduced cardiac function, the question from the cardiologist was, will she benefit from a bypass procedure? Looking at this, we can again see there's reduced perfusion in an area, but there's also no uptake of energy substrate, meaning this is scar tissue, so the patient will not benefit from an invasive procedure such as a bypass. And no bypass surgery was performed, and instead we could do optimized medical therapy. Looking at MRI, this is a 45-year-old woman. She had a severe heart arrhythmia, sudden AV block, which may cause death. MRI says there's some edema in the myocardial wall. What is this? We think that this could be an inflammatory disease, sarcoidosis, and we have a very good tracer for that, FTG, which very nicely images the active leukocytes or white blood cells, both in the lymph nodes, but also in the heart. And we can see that there's much activity in the heart, meaning that this patient will benefit from severe immunosuppressive treatment. And she had a pacemaker and anti-inflammatory drugs. For treatment monitoring, we can use the same tracer, looking at metabolism. If metabolism is going away, then the disease will be well treated. So this was a woman, again, she had cardiac sarcoidosis. She had been treated for a long time with methotrexate and prednisolone. What's her status? And then we do a treatment monitoring scan. And again, I hope this is obvious that where before we saw lots of activity in the septum, there's really no activity anymore, and the patient can have her anti-inflammatory drugs reduced. One of the last cases I'll show you is that we can, when we quantify perfusion using PET, we can see the coronary flow reserve, the ability of the microvasculature and also the epicardial coronary arteries to dilate. And this is a very significant predictor of death, meaning that if you have a reduced flow reserve, you're likely to die from cardiovascular disease more than if you don't have it. And then treating cardiologists will know that this is a patient who should have aggressive medical treatment. So in this case, the clinical impact for this patient will be precise risk stratification and really treatment guidance. So I'd like to end my talk by concluding that functional imaging is really complementary to anatomical imaging. We often qualify what's already been seen on radiology, and may in some cases serve as another gatekeeper before we send the patient to invasive procedures. So we provide diagnosis whether to stent or not to stent in the narrowing of the coronary arteries. We do prognostication where therapy should be optimized or whether you can stand back. And also treatment monitoring, which is important since we do not want to treat patients for too long. So with that, I would like to conclude my talk.
Thank you very much, Lars. And now we are heading to the second part of this session, and we will hear a real life story.
Thank you. Dear Dr. Jerković, dear esteemed representatives from the EU institutions, dear health professionals and stakeholders. 3 weeks ago, I received a rather unusual invitation to come here and share the story of the events that led to my heart surgery in English. To be honest, that caused me quite a bit of stress, which, as you can imagine, is not exactly ideal for someone with a heart condition. But thanks to Dr. Salgado, I'm standing here today, able to tell this story. And for that, I will always be grateful because he saved my life. My story is not a typical one. It began in September 2015, when I experienced a sudden sharp pain in my chest, near my heart. A week later, it happened again. At the time, I did not pay much attention to it because I was going through a particularly stressful period in my life, and I assumed it was related to that. The following month, I went on a 3-week trip and felt perfectly fine. But after I returned, the pain came back. They were still unpredictable, sometimes during exercise, sometimes while resting. Occasionally, I would have 2 or 3 episodes in a week. At other times, I could go for days without any symptoms at all. Gradually, I started paying more attention. What made it confusing was that none of the classic warning signs were there. The pain did not radiate into my left arm. My blood pressure was normal. I had no shortness of breath, no unusual fatigue, and my appetite remained excellent. I did not smoke. I did not drink alcohol. I stayed active and exercised regularly. And yet something did not feel right. I kept my concerns to myself because I did not want to worry my family or friends. But that changed in March, when I was visiting a friend and experienced another episode. This time I mentioned it to her. And in true nurse fashion, she looked at me and said, "Stop playing doctor and get yourself checked." So 2 weeks later, I finally made an appointment with the cardiologist. But the results were reassuring. The ECG and the echocardiogram were normal. The blood tests were also normal. Even the exercise stress test showed nothing unusual. My cholesterol level was around 200, but my triglycerides were low and my HDL cholesterol was high. I had no family history of heart diseases, and my BMI was only 19. From a cardiologist perspective, I was hardly a high-risk patient. The most likely explanation, he thought, was esophageal spasms. I was prescribed medication and told to return if the symptoms continued. But something inside me said that there had to be more to the story. I asked for additional investigations. And a week later, in April, I underwent a CT angiography with Dr. Salgado. At first glance, the scan looked almost completely normal, 99% normal. Naturally, I felt relieved. But for Dr. Salgado, 99% was not enough. He wanted certainty. The next day, he personally called me and asked me to repeat the examination. And looking back, that phone call changed my life. The second scan revealed what the first had almost missed, a severe narrowing of one of my coronary arteries. And from that moment on, everything happened very quickly. My cardiologist was informed immediately, and a week later, I underwent a coronary angiography, and soon afterwards, I was scheduled for heart surgery. Following further assessments, I underwent robot-assisted bypass surgery in Aalst on May the 9th. And 6 days later, I left the hospital. I then completed 3 months of cardiac rehabilitation and gradually returned to my normal life. Today, I'm back at work. I enjoy all my usual activities, and I continue to have yearly follow-up appointments with my cardiologist and vascular surgeon. Most importantly, since my operation, I have not experienced a single symptom. That is why I'm here today, because one doctor was not satisfied with 99%. One doctor looked a little closer. Dr. Salgado, you have my deepest and most heartfelt gratitude. Thank you.
Thank you, and also thank you for sharing. I know it's not easy, but it's very much appreciated. And now we are thrilled to hear another story, which is a little more rare story to hear, but happy to have it.
Okay, thank you. Okay, I was asked to give my personal view on what happened to me as a patient, and I'd like to share that with you. 7 years ago, life was beautiful, and you see me here when I was in holiday in Tenerife. But the first signs, however, came in 2016. In a routine blood check, there was not enough protein in my blood, and the doctor thought it was maybe an error or a transient problem, didn't give any attention to it because I was in good shape. But 3 years later, in June 2019, I felt tired too soon during my holiday. And I had my general practitioner do a blood check. And she said, there is not enough protein in your blood. Is it possible to give a urine sample? So I did. And she said, well, the protein I was expecting to be in your blood, I find it in your urine. So immediately she referred me to the University Hospital of Antwerp. And I came there in the nephrology department. And they did a lot of extensive blood and urine samples. And the evidence was that something was wrong, but they couldn't find what was wrong. And they wanted to know. And so they said, okay, we will give you a kidney biopsy and we will give you a bone marrow puncture. Not the most pleasant examinations, as you can imagine. And then the diagnosis came, you have amyloidosis AL. This is the good news and the bad news. The good news is we know what you have. The bad news is you have amyloidosis AL. Amy, what? That was my Amy, what? Never knew. Okay, it's a malformation of plasma cells. It's incurable. It destroys your kidneys. I had only 30% kidney function left, nephrotic syndrome. And it affects also the heart, impairing the pumping function and until you die because, okay. There was no patient organization. And the only thing I received was a brochure, amyloidosis awareness. And then you read this. in yellow, the average survival for AL amyloidosis is about 12 to 18 months, and only about 6 months for patients with severely impaired function. That's the message you receive with the diagnosis. The psychological impact of such diagnosis is I was completely in shock, but I came home and I didn't tell my wife because she's my second wife. The first wife, she died from another rare disease, and she's very, very caring, and then she will be complaining, and there is a lot of negative energy around you. So I told her I have a blood disease, which was not a lie, and USA University Hospital should take care of me. Okay. I went for a second opinion to Dr. Google, you know him? And I found only confirmation for the bad prognosis. And I took then the most important decision in my life. I decided not to be afraid. Not to be afraid for the death, not for the disease, not for the chemotherapy. Because when you think chemotherapy, you see people lying in a chair, losing their hair. There is not much to lose anymore, but okay. I decided not to be afraid for things that eventually might not happen in the future. But what could have done better? Why did the doctor neglect the first symptoms? Because the sooner you know that you have amyloidosis, the less damage is done. So imaging with SAPScan, like they do in Holland, would have revealed the disease earlier. Earlier diagnosis could have prevented organ injury, and the quality of life of my would have been better. But because there was no patient organization, I made it myself. I needed that, so if it's not there, I made it myself together with 3 other patients. And in January, 19th of January 2024, we founded AMIBEL, which is the patient organization for Belgium for all people with amyloidosis. We have now new and better documentation for the patients, and we distribute that. And we made a national press coverage in 2024. And every time that we were in the newspapers, the number of members increased tremendously. And we were for 3 times in the Flemish and in the national parliament in Belgium to fight to defend the rights of the patients. And we worked very, very close together with the people in Holland. In Holland, they had in that time 2 EANM expertise centers, one in Utrecht and one in Groningen. And in Groningen, they are specialized in the ATTR form of amyloidosis. And they have a SAPScan, and they gave us a very, very good round trip in the hospital, and they showed everything what they do there. And they give early detection of amyloidosis, excellent view on the progression of the disease, and they are an EANM center. In Belgium, there is nothing. And that's the heartbreaking difference between Belgium and the Netherlands. In the Netherlands, amyloidosis, AL, my form of the disease, is registered and recognized as a blood cancer. And I received their yearly report. And I saw every year 140 new patients are registered and treated in the EANM expertise centers. But I think, okay, that's interesting to know. So I wrote to the Belgian cancer register, and they say, oh, amyloidosis AL is in Belgium not a cancer, and it's not a major disease, and therefore it's not registered or recognized. So it was very frustrating. AMIBEL receives no support from Stichting Tegen Kanker or Kom Op Tegen Kanker, but most important, people don't receive the best possible treatment. They need to be lucky to find a knowledgeable doctor. So the take-home messages are, it takes more than 4.1 years from symptoms till diagnosis. That's the average. It takes an average of 5 specialists before they find the disease. And we know the earlier the diagnosis, the better the prognosis. I remember there was a lady, she called me and she said, okay, I want to become a member of your organization. And 2 months later, I received already a mail from another lady, and she said, well, mother died already because the diagnosis of amyloidosis was put too late. And one of the most important causes of death among our members is euthanasia, because people see what they can suffer and they decide to have a dignified end of their life. Okay, therefore, awareness about rare diseases like amyloidosis needs to be increased in all possible ways, and targeted imaging could have made earlier diagnosis possible. The quality of life of the patients and their families could improve. And then, okay, patients need early diagnosis, need access to appropriate imaging. We need referral to expert centers and strong need for better awareness among the healthcare professionals. And equal access to innovative diagnostics and equal reimbursement for innovative medication and procedures. Like there are things that are good in Holland and bad in Belgium, but the opposite is as well. We have reimbursement for some good medication, which is not in Holland, and they are fighting for that. So if we are speaking for Europe, then we are asking ourselves, if it is approved and it's working and it's reimbursed in some countries, why is it not for all European countries? That's it. Okay, thank you.
Now we have the last part of the last two presentations that are looking a little into the future.
Thank you very much for the kind introduction, and good afternoon, good morning to everyone. So we move ahead after these two beautiful real life stories to the new frontiers in cardiovascular imaging. And I'm starting wondering, how could we envision the future of cardiovascular care, and what can we do as radiologists to support this vision? And firstly, I would say that it was clear also from the previous presentation, the old concept of radiology and maybe of nuclear medicine was related to morphology. Today, more and more, an image contains information about biology of the disease and even prognosis. So we move from morphology to structure and mechanism. This is something that is already happening. Second point, this was also mentioned, I think for years there has been a focus on standardization of protocols. Today, precision imaging and precision care means to give the right treatment to the right patient and the right time. And this is something in which our activities are highly contributing. And this moves further to a population health concept that sounds very much ambitious, maybe fits very well the safer plan we are talking about. So extending what we can do to an individual, to the whole population, and finally extracting prognosis. I'm a radiologist, I'm doing diagnostic imaging, but more and more prediction of events is something that makes sense to avoid the stories we said. So starting from the first point, anatomy, biology, and physiology. I'm starting with this great movie provided me by Professor Al-Qadir from Zurich, which shows exactly what we want to avoid. Histology is the ground truth. If we have a plaque and a plaque ruptures, this can lead to a complete obstruction. So, of course, doing a diagnosis in a late phase is not beneficial for the patient. And today, more and more, as I mentioned, an image contains information. This is a soft plaque on a CT angiography. So we see the plaque and the fatty composition, but not only this. From morphology, we can look what is surrounding the plaque itself, the so-called pericoronary tissue or the environment. And finally, imaging and radiology is becoming also very much oriented to physiology. So not only static images, we are able to quantify what happens in the vessel, if there is a perfusion impairment, so the vessel are patent, how much blood is arriving, and what is the level of the impairment. And this is something, of course, that is already ongoing. It's a transformation that is taking place. And the plaque biology, so what we see from our images also determines myocardial injury and myocardial infarction. And if you look at what we are also able to do after an event. This is also very useful. The old definition from pathologists of the infrared pale area. So what is the area where the event occurred can be clearly visible with MR, with the new techniques we have looking at the edema, so the accumulation of water, if there is a functional impairment, inflammatory component, et cetera, et cetera. So the message, I don't want to be too technical here, but connected also to a story we heard from Professor Salgado, is we are able to extract much more than a simple morphological information. The second concept, looking at the future, looking at the transformation, is already ongoing. Standardization has been the right approach for decades. So decision based on symptoms, risk factors, and risk tables, this works pretty well. But of course, if we add value with imaging to the patients, combining all the information I told you about, the standardization moves to personalization. So precision care means to treat the right patient with the right approach, and imaging is driving this, and this is also recognized in the guidelines that have been published recently. And what I find particularly interesting, there was a gap between what we were doing and what was done in the operational room, in the cath lab, in the surgery. And even more today, our images can fill the gap, can build a connection. And this is an example, for example, this is a video and animation of a vessel showing multiple calcifications. As you can imagine, in the light of treating such a vessel, knowing where is the calcium, how hard it is, where is it located, can be extremely helpful also in driving the procedural planning. And this is something that is ongoing and I think will be more and more in the future in the light of a multidisciplinary collaboration. So this patient has a terrible diffusely calcific coronary vessel. He was treated, and knowing where's the calcium, what is the distribution, can be really meaningful to understand how to do. And third, we talked about population, we talked about standardization versus individual treatment. The next step should be to move to population care. We already talked about the availability of infrastructure, and a patient's journey was already heard in the beautiful real life stories, starting from the clinical assessment to the outcome. But today we should, I think, exploit the millions of scans that are doing yearly in Europe for better health. So ideally, we should build a European imaging network, a biobank, of course, secure data sharing, use artificial intelligence, this has been mentioned, to extract new biomarkers and eventually extend the data we have from our images to the whole population. I think what is very interesting, this was published last year in Lancet, so one of the most important medical journals, and was looking at the risk profile from general scale published at the European level. And what sorts out here is that there is a difference between middle income and low income countries related to what is theoretically a low, middle, and risk profile. So in theory, we stratify patients according to their risk profiles, but even the geographic localization makes a difference in terms of percentage of cardiovascular events. And this is something we should work on to give access to healthcare and equal possibilities of survival. And finally, the last pillar, the last transformation that is already ongoing was mentioned by the previous speakers. Today, we are doing diagnosis, radiology. I'm a radiologist, it's diagnostic imaging, but more and more we should shift to prediction. This is a patient, by the way, a colleague, so it's the worst risk factor category possible. You see this patient has a lesion in this coronary. We were able to extract in this beautiful colored image information about flow using what is called computational flow dynamics, so an algorithm based on informatics. But in the same patient, artificial intelligence is providing information about what is called the overall plaque burden. So how much disease does this patient have in the coronary arteries? What is the distribution of calcifications versus soft tissue lesions? For non-doctors attending here, whatever is soft, of course, is at higher risk of transformation, of rupture. And this really makes sense because we can stratify and predict the risk of events. This was a large study published in the Lancet again a few years ago, where measuring the plaque volume with AI predicts events and the risk of myocardial infarction. So a tailored treatment means how to treat whom to treat, and what is the risk of developing events. And finally, we were talking about the infrastructures, how to deal with the future. These data are taken from the registry. I'm the elected president of the European Society of Radiology. We gathered in 10 years almost 500,000 patients who were doing MR and CT all over Europe. And you see there is a constant increase in the numbers of examination. CT increased in 10 years 4.5-fold. So certainly there is an awareness. Even MR is growing, a growing adoption, favorable safety profile. The tests are extremely useful, so we should use it, and we are ready for innovation. The infrastructures are there, as also mentioned by Professor Salgado. And before concluding, not only because I'm Italian, but I think we are used to think that technology is the most important thing. Innovation begins with a vision. A very nice example from Leonardo da Vinci, 5 centuries before cardiac MR. He was doing his anatomical drawings and literally described the possibility of having multiple layered concentric vortices in the proximal aorta. That is, we were starting with dissection, and 5 centuries after, with MR techniques, it was, of course, right. So, of course, technology is important, but even the expertise and the vision is really something that makes the difference. So we are technologists, but we are also doctor, proudly, I would say. Coming to the conclusion, translating innovation into better care. Firstly, as I mentioned, radiology is not anatomy. Radiology is everything, it's comprehensive. And I think we could extract information about this is biology and physiology, and that's very interesting. Secondly, as mentioned already previously, we should extract biomarkers and transform this into an evidence for prediction and decision-making and into routine care. And finally, I'm a strong fan of multidisciplinary expertise. This is a field where different competencies, as we see today, can contribute complementarily for the interest of the patient. And this is totally aligned with the CIFR plan we are talking about today. Thank you so much.
Thank you very much, Marco. We are live, so we have last minute adjustment. So now, before concluding the session of the talk, we are very pleased to have online a colleague, dear colleague of Professor Evis Sala. She is currently Ministry of Health from Albania. By the way, if you want to be a ministry, you have to be a nuclear or a radiology, because also in Italy we have a nuclear medicine currently as Ministry of Health. So I'm sure Evis will have to contribute with a very quick statement, and I know you have to leave the meeting at 12.
Thank you very much. Thank you for inviting me. Indeed, I think between me and my colleague minister in Italy, we cover all aspects of radiology, from nuclear medicine to imaging, a testimony of we can work together and integrate. So I'll bring a little bit of a view of someone now which is in policy making, but have gone through being an imager, going from what I call a 2D gray imaging when I started my training to really getting the functional imaging on board, the physiological imaging. I come from the oncology side, not from the cardiac side, but things are interchangeable, of course, and one learns from the other. To what I call of course, the 3D and the 4D, we know what it means in imaging. I could see what Marco was the images with the flow and everything else. But what I call is the 5D is actionable imaging. So I think it's important then for the policy making to see how crucial the imaging is. Definitely in Albania, but I think I'm looking at a country which is joining the European Union in a few years. So I'm working that in mind. Health system can progress fast. We, as a radiologist, working together with our colleagues, I feel we're like orchestrators, integrating imaging with clinical knowledge, and of course with the layer of AI on top. This has also made it, the decision support to really reach another level. So in the policy side, I know we are a small country. We are small enough to fix, but big enough to matter. And having a radiologist in those positions, I think it helps to be aware, realize that how key is to have imagers that understand what imaging is, what medicine is about, but also have a vision to implement it and really implement it in a multidisciplinary matter. And it goes as the previous. I mean, I joined a little bit early, so I could see what the previous speaker was showing and joining and seeing it in the whole pathway. And this is very important. I think as imagers, we have the whole. We are transversal. Our specialty is transverse. We see the whole pathway, and in this job now, when you set policy, you know how important that pathway is. Really, in all the steps. So I'm a very pro and always have been promoting the integration. I'm always promoting that in the we should work together in an integrated manner. But the imaging now is indispensable, and it goes through all the patient pathways. So please keep in mind that we even in policy making, the pathway is very important. And I think at the end of the day, this is what would mean. The outcome of the patient, it really depends on a well-organized, orchestrated pathway where the imaging is key. I know I'm biased to imaging, but I'm more so biased now sitting on the policy side, where I can really understand the impact, not on the hospital level, not on a society level, but on the whole country level. Again, small enough to fix, but big enough to matter in terms of setting the examples on the policy maker. Thank you.
Thank you. Thank you, Evis. It's very important having your view, and thank you for the work you are doing also to keep the community together and alive. Thank you. So now we can keep on and conclude the round of talk and then opening the round table. It's my pleasure, Rimmer, to give you the floor.
Waiting on the slides. Yes, thank you very much. Where are we looking at in nuclear cardiology? I'm Marina Sluit, nuclear medicine physician, and how can we contribute to the EU Safe Hearts plan? Yeah, we know we want to detect earlier the diseases, and detection is based on biology, you think so? So we have to add on to stenosis and also to anatomy before the symptoms even appear. And so we can also look for better treatment selection this way. So we can also reduce over and under treatment. That's also important with this kind of imaging. So ensure the right therapy to the right patient at the right time. Anatomy is the gatekeeper, we know already, and but biology holds the key to predict all these the events. And with nuclear medicine techniques, we can image multiple biology processes like imaging inflammation, the infections, fibrosis, atherosclerotic instability, and also to look at a small vessel disease. This is an example of a patient had a CT with the calcification stenosis, but this traces, this fluoride, this PET-CT trace, can also quantify and also image the real calcification process in the stenosis. And why is it important? Because it can also better predict also events in the future. As you can see here, without any activity of calcification, the risk is zero on heart infarction in the future. But when it's highly calcified, you have a 7-fold higher risk on myocardial infarction by using this calcium tracer. If you look at the next step to a patient with coronary microvascular disease or small vessel disease, it's actually a major under-recognized disease, particularly in women. They can have typical chest pain based on heart ischemia, blood reduction in the heart, and they do not have an obstructive heart disease. So anatomy is in this case failing, but they still have higher risk on infarction, for instance. And PET imaging can image this microvascular dysfunction. This is an example of a 40-year woman with a normal ECG, stress test, and echocardiogram. And what now? You have to perform imaging. See, you underwent a CT here, zero calcium, nothing to see on the CW and calcium score is 0. Also on a CT angiography, and also showed no stenosis. So next step was also to perform a PET scan, PET perfusion scan to look at stress and rest. How is perfusion of the heart? Every red number is abnormal in this patient. So there's a high reduced stress flow in this patient. This is a typical example of microvascular disease. So learning point is this typical example of multimodality approach in this patient. PET can image also dysfunction. We can start optimal medical therapy and we prevent an infarction. And it's mainly seen in women. It's also now taken up in the guideline to also perform perfusion imaging in this kind of cases. The next step is also now presented by a patient group, by Mr. Lippens. And this is cardiac amyloidosis, another type, but it's a systemic disease. This type is produced in the liver. You get a lot of proteins in the blood. It's misfolding and it's deposited in organs, particularly in the heart. To get a diagnosis, you do normally in the past an invasive procedure, biopsy with a needle in the heart to get a diagnosis. This is a patient, male. He has some signs of heart failure. And the question was, do we have to deal with cardiac amyloidosis? And these days you get a non-invasive test, a bone scan test, and we see a light over the heart. You can see it brightly. That means this is a diagnosis for amyloidosis. And that avoids also years of delay in diagnosis. This is a spontaneous type of amyloidosis. We call it ATTR amyloidosis. We also can have the genetic variants, and these patients know already I may develop heart failure, but I'm not sure, and you have to follow up this patient. But not that every test is perfect. As you can see, bone scan is negative, and maybe was still suspicion of cardiac amyloidosis. Then we perform a specific PET scan. You can see the movie here. With the Pittsburgh compound, it's actually a compound also used in Alzheimer's patients because they have also amyloid deposition. But this time used for the heart. So look, is an uptake. You see a highly uptake in the heart. It means this patient is a very active cardiac amyloidosis. So this test, also the new test, ensures no missed diagnosis. And we should be very careful, particularly in this group of patient genetic variants. Next step is new radiopharmaceuticals. This is a pharmaceutical to image active fibrosis. This is a patient with infarction of the anterior wall of the heart or left chamber. But this tracer, this FAPI tracer, shows an extensive activity around the infarction. It means a much larger area is involved in the infarction process. But the amyloidosis of the fibrosis is very important to know, also to follow up, because it can give remodeling after infarction and can also result in heart failure. And this information can help also to develop new therapies like antifibrosis therapy to add on to the conventional cardiology treatment to prevent heart failure in these patients. New development techniques, this is very important for our field. This new large axial field of view, which is actually some kind of total body PET, very large system. It's a very sensitive system, 40 times higher sensitive. It means an extremely low radiation dose to the patient. It goes really fast, 3 minutes instead of 20 minutes. So high throughput of patients, and patients really like it. And you can also scan our patients with low dose in children, pregnancy. You can even use them of a potential screening tool. But most importantly for the cardiovascular field is we can image the cardiovascular system as a whole, because I believe it's a systemic disease and not a heart disease we are looking at. And you can look at inter-organ interaction like heart brain, heart kidney, heart liver. Even the cuts can play a role in heart disease, heart failure. So with this system, we can do it in one shot. And also quantify the dysfunction, different organs, how they interact with the heart. We collect a lot of data, also with this kind of new systems. We analyze it, we reconstruct it, want to share it, and also to archive it. And in the end, we also want to make AI predictive models, including the clinical data. So really, you have to look for that, how to share it in Europe, also with the data platforms, and to share it with each other, and to come up with an optimal predictive models in this kind of patients. How to implement this large, this total body PET systems, for instance, in children. This is a patient, a newborn, was suspected of an infected heart valve, endocarditis. This patient with a 3-minute scan without any sedation anymore. So it's no team needed anymore, no personnel for that, no agreement on that, less stress. So we can do it very quickly now. We scan it very quickly. And you found a hot spot there in the heart with the arrow there, the yellow. On the valve, there was the endocarditis, and the focus on the feet. You can see there, that was the feet. So the patient, this little newborn, and with a local treatment, also systemic treatment with antibiotics. And it was repeated also, the echo at the end was normalized. So this is a very nice example how to implement this kind of system in this patient group, this vulnerable patient group. So if I conclude for nuclear medicine, it can transform the cardiovascular care in line with the EU Safe Hearts Plan vision, because we detect on molecular level the biology abnormalities in cardiac diseases that can transform also the personalized care and can be better used in healthcare resources. But we must invest, of course, in matching capacity for all states. Everybody should be included to ensure effective implementation of our EU Safe Heart plans. We should develop a comprehensive roadmap for us, for the cardiovascular imaging group, with all the relevant stakeholders to harmonize the practice, for also training, drive innovation, including AI, and support equitable access. So, and we should continue investing in research and also evidence generation. Thank you very much for your attention.
Thank you. Thank you to all the speakers and the patient particularly. Now we have, I will have help from Professor Catalano, a dear colleague and friend, former president of the ESR, and we will now start a panel discussion. We have prepared some questions to trigger a little our panelists, and then we will open up the question and answer. Please, Carlo.
So, good morning, everyone. And it's a great pleasure for me to moderate this panel discussion together with Professor Erba. And now first of all, it's my pleasure to introduce also our eminent panelists, who are Isabel Boster-Crisantou, health attaché from the Cyprus government here in Brussels, Professor Luscher, President of the European Society of Cardiology, and we have also online Professor Philippe Pereira, President of CIRSE, Cardiovascular Interventional Radiological Society of Europe, and also online Professor Vlastimil Valek, who is a radiologist and also has been Minister of Health in the Czech Republic. So, Paula, maybe you can start.
Yes, thank you. So, Isabel, I have for you a first question. You are also a professional with a previous history of experience in the field. So my question for you is a little general about the access for patients. So it's about the collaboration to ensure proper access to all patients in EU. What's your perspective? What have you matured in this respect?
Thank you very much for inviting us to this beautiful roundtable here. And to be able to answer these questions, we're going to have to look at the different activities that we have been discussing in the Council. And in the Council, we obviously discuss what the Commission is coming up. So we've had a cardiovascular plan. It has been presented in December. And so we have seen, and from our previous experience and from all these talks today, we have seen that medical imaging, that the radiology, that the nuclear medicine can do an amazing job. And we have in the cardiovascular plan the detection, early detection and the screening aspects, but also the treatment, of course. And I would also like to mention these other flagships that are in the cardiovascular plan, which is cross-sectional themes that go more into closing gaps and the AI aspects, as well as the inequalities. So we have now seen that radiology really can help in these early detection, in creating, looking at the hard structures, looking at the function, looking at the biology, looking at the viability. Everything you have presented today is amazing progress and that we have in this area. But we cannot think about now imaging without also tying it in with artificial intelligence. And when we're thinking of AI, we're thinking also of quality data sets. We're thinking of structured reporting. We're thinking of harmonized imaging protocols and harmonization across Europe on how we do it together. And this is exactly which leads me to think that there's going to come, or there will be coming, council recommendations under the Irish presidency. So these recommendations are really policy recommendations that will bring the member states together. We're going to be trying to work together as we've done in the past through EU for Health and so on, but bring it to the next level, to the policy level, and trying to integrate it into the member states. But you know that health is still a national competence. So if a member state decide to introduce a new policy, it's because the member states will decide to do that. And we know about the discrepancies between the countries, so countries will need support to be able to do this, to do it together. And then, so this brings me again to support. And the support was also some important files that we have been working on under the Cyprus presidency. We've done the first, let's say, work on these MFF files. You know that EU for Health has been replaced by a broader, bigger, ambitious European Competitiveness Fund. But as trying to defend the health aspects, we have done everything possible to bring into these EU for Health, the new ECF concepts that were born, as MEP Andriukaitis told us, the European Health Union, these working together. We've brought in aspects of early detection, screening, then the treatments, and then non-communicable diseases. It's all in there. So your concern of access has also been integrated in the ECF. Though I need to tell you, when it comes to infrastructure, we're going to have to work on the national and regional partnership plans, because this is national competences to bring the infrastructures. But we heard there is infrastructure around, we just need to be able to use it in a better way. So back to the ECF, we've put equitable access, and we've put equitable access in two aspects: innovation that can enhance equitable access, but also production afterwards that can bring equitable access to the patients across Europe, because it is a concern. So to conclude briefly, it is what has worked in the past, impactful projects that you have done, the networks that have been created under EU for Health will also be around for us to work together on this new mission that we're having. So it's good news, I think, for the society and for us as health professionals to care for our citizens. Thank you.
So now we'll move on to Professor Luscher. So Tom, cardiovascular care is really moving and increasingly becoming multidisciplinary, as most medicine is. How can we move beyond discussions and somehow focus on ensuring the right test for the patients at the right time? And at the same time, you are currently the president of the European Society of Cardiology. What are the role, and what could be the role of scientific societies in this setting to support this shift that any field in medicine is doing very rapidly and should be done also for what regards cardiovascular care?
Thank you very much, Carlo. It's a pleasure to be here. Thank you very much for this invitation. I'm particularly delighted to meet radiology colleagues, because multidisciplinary approaches are really also at our heart. In fact, as you know well, we were fortunate with the European Alliance for Cardiovascular Health, which involves 23 medical societies, mainly focusing on cardiometabolic spectrum. And I was also privileged to meet many commissioners and to work with the DG Santé on this plan and advise them on what we feel would be the most important content. And we're really delighted that they did a very good job, and we were pleased to present it together with Oliver Varhelyi in our meeting in December 10, 2025, also last year, here in Brussels. And as you know, there are 10 flagship initiatives in this plan. I would say 6 of them primarily focus on prevention and artificial intelligence. Oliver Varhelyi is as much enthusiast of artificial intelligence as we are. And, you know, we already, all the guidelines that were mentioned, I noticed this with pleasure from the European Society of Radiology. They're now available in an ESC chat. You can type in and, of course, get recommendations. Also, what imaging should be used. So we should really work there closely because that's part of our guidelines, of almost all guidelines. So prevention is mainly primary prevention and using artificial intelligence to make it personalized, using, of course, biomarkers, clinical deep phenotyping, also visualization, I would say, of the arteries that are easily accessible, like the carotid or the femoral arteries. And indeed, you know, it's maybe not known to many doctors that even if you are at high risk, only half of the patients really develop atherosclerosis. So it's really an additional information. And then we also have a health check, and this health check imaging has not been included because mainly of cost considerations. So it's mainly clinical data, the lipids, now new creatinine, lipoprotein little a, and we now managed also to have NT-proBNP included, as it looks like, after further discussion with DG Santé and others involved in this. And we also added an ECG, which now through artificial intelligence provides massive more information than we see when we just look at an ECG. And then, of course, there is, of course, closing the cardiovascular research gap. As you know, we're really in massive competition with other continents, America by tradition, but now China. I would like to inform you that for the second year, China has submitted most of the abstracts. And Carlo, you were in China. It's impressive what they do with robots and AI. They have a hospital with 20 cath labs. It's, I don't know where this is going to be end. So we have to really wake up in Europe to integrate. And I'm pleased to hear that you want to integrate imaging with biomarkers, also with new features such as the fat attenuation index developed by my friend Charis Antoniadis, to really get much more insight into personalized and precision prevention, be it primary or secondary in nature. And then, of course, I heard also the question on accessibility. It is clear that mortality is massively different in Europe. I just gave a talk about this at the European Medical Agency yesterday. That's why I'm a bit late and apologize for that. It's also because of the train system in the Netherlands. I thought they're very well organized, but it wasn't. But anyway, I'm here. And so when we look through these 27 countries, if you are in Bulgaria, your mortality of cardiac disease is like 5 times higher. While if you live in France, it's almost the same on cancer and cardiovascular. So there's huge differences. So we have now been in contact with all 27 nations, their national cardiac societies, and with many ministers of health and finance, and in some instances in Poland and in Cyprus also with higher ministers, even deputy prime ministers and prime ministers, to make sure that there is not only this cardiovascular health plan of the European Union, but in each of the 27 countries, there is a plan that complements the overall plan with the specific needs of these different populations. And so I think this is a fantastic opportunity for Europe at large, and we are very much into it, and we're really open for a good collaboration, and Carlo knows that, that integrates imaging with biomarkers, with outcomes. And here, of course, the European Society of Cardiology wants to further develop the EuroHeart study. We have the EuroHeart registry that is complete representative data from, particularly from the UK, Scandinavia, but also from Romania and Hungary on certain diseases. So I think this will allow us to really move to AI-based personalized medicine.
Thank you, Tom. Thanks a lot.
Thank you very much. We have the next two panelists online. I'm very glad and looking forward the comment of Professor Pereira on the contribution of the interventional radiology perspective to the Safe Heart Plan. We are a little ahead of time, so I would really ask you to stay in a couple of minutes statement. Thank you.
Yeah. So thank you for inviting me to join this session, and I would have liked to be in Brussels, of course, with you today, but we have the most important meeting of our society starting this afternoon. Fantastic to see for me that there is a multidisciplinary approach similar to cancer care. It is necessary, as we all know. Maybe I would love in the 2 minutes I have to approach or to add another aspect of this cardiovascular approach is the condition of patients with peripheral arterial disease, because peripheral arterial disease is a powerful indicator of a global cardiovascular risk, and it remains frequently underdiagnosed and underscreened and undertreated. So I believe that including patients in this European strategy that is cardiovascular means also vascular, including patients with peripheral arterial disease in a European strategy for coronary artery disease makes, in my opinion, a strong medical, economic, and public health sense, because these conditions in this patient are deeply interconnected with the same disease, the arteriosclerosis. So I would like to, in the few times, express interest of the CIRSE, the Cardiovascular and Interventional Radiological Society of Europe, interest and availability to further collaborate and to contribute to this fantastic plan. And I strongly recommend to introduce vascular pathways in center of excellence, supporting among others also by interventional radiologists. If we want that different European states could be able to support infrastructure and workforce in the field of interventional and cardiovascular interventional radiology. Thank you very much.
Thank you. Thanks a lot. Also for Professor Pereira, also for being very short and express your concept in a very short time. And now we move on to Professor Valek, Professor Vlastimil Valek, as I said before, former Minister of Health of the Czech Republic. And hello, Vlastimil. We would like to invite you to outline the national implementation of the EU Safe Hearts Plan, including key opportunities and challenges, as well as the central role for medical imaging, including radiology and nuclear medicine, in national cardiovascular health strategies. Please, Vlastimil. Oh, okay. Okay. So there are technical issues. Maybe we want to move on to.
Yeah. Since we are not able to connect, maybe I would like to ask co-chair or co-chair. She's with us today to give a word of welcome and comment, because we really are doing this all together, professional, patient advocates, policymaker, but also industry.
Thank you so much for inviting us here, and I'm very, very glad to represent COSIR and the voice of the medical imaging industry here. This has been the most fruitful discussion, and I have taken great, very notes on everything that has been shared. It's indeed very important that we have the discussion because, as my colleagues have mentioned many times, the current efforts at the European level union are very much focused on the prevention. But as we all know, the cardiovascular burden very much depends not only on the ability to prevent, but also to detect and to provide the necessary care to the patients that have been identified as at risk. And today we see how much value the actually imaging can provide to correctly identify and to provide the care that the patients need, not only to cure, but also to extend the years of good life. A lot has been mentioned, and I will not be able to cover everything that has been mentioned today, but to maybe stress a few points that the colleagues have mentioned. Indeed, first and foremost, we would like maybe to encourage the colleagues here to work with the national stakeholders, because we have done our utmost to make sure that the Commission is really putting the focus on the cardiovascular care, including stroke. That has been mentioned here multiple times. So the plan is on the table, and now a lot of efforts are moving to the national stakeholders. And here the support on the ground would be fundamental. And here we need to stress, in view of the value of the imaging, how much is important not only to look at the primary testing and the primary screening, which will be very much designed with the cost effectiveness in mind, but also to ensure that there is a proper follow-up, that there is a proper referral, and that we do provide the patients with the confirmatory diagnostics that would not be possible without the more advanced solutions. So not only the blood testing and measuring the BMI and the other risk factors, but also the MRIs, the CT, and other solutions that will be necessary to find the precise diagnosis and to provide that care that is needed. Another very important point here would be not only the screening recommendations that will come before end of the year, but what we will be working on together next year on the integrated pathways for the patients. So basically what happens after you have the screening. And that's something very important where we all need to remain engaged and to provide exactly the type of evidence that you have shown today, including the very important patient perspective and patient stories. One thing that my colleague has mentioned, and I want to put an additional emphasis on, is the importance of the funding, because it's really important, and we've seen that also with the European Cancer Plan, that without providing the necessary support, certain countries in the EU will simply not be able to provide the equitable care to every patient as envisioned by the European stakeholders. So continuing stressing and putting emphasis on the need to have the healthcare funding also in the next financial framework, that remains of utmost importance. And maybe, if I may, my last point, we've touched upon the access to innovation, access to the necessary equipment, and the topic of AI. And of course, having you all here and listening to your stories and how you use the imaging solutions that we're providing, it's very encouraging how much you rely on this and how much value you see in that. I must mention that we as an industry, we do struggle with the current framework to make sure that we can still launch our innovation first in Europe compared to other markets. And seeing how much work has been done by the colleagues of the Cypriot presidency, we're very encouraged to see how much sense of urgency there is still around this topic. Of course, it's important that we have workable solutions that do maintain the necessary, not only patient safety, but the safety of the healthcare professionals that are using them. And one specific point I must mention is, of course, the AI. There's a lot of potential, there's a lot of value, as has been stressed today, that you already seen that. We would encourage, of course, here the colleagues to support the Commission proposal to make sure that when we move forward with with our placement of the solutions on the EU market, that we can benefit from the streamlined procedures on how to do that. And therefore, we of course encourage to support the Commission efforts to make sure that we as an industry may still continue doing so. That would be it on my side. And thank you so much, everyone, again, and thank you so much for having me here.
So just a few words to conclude this very short panel. So first of all, thank all of you for these very impressive words, even if short, but I think they were relevant for the session today and also for the specific topic. Also to conclude, probably would be also important to stress that the imaging societies, the Association of Nuclear Medicine and the European Society of Radiology probably would be strategic in the alliances, especially the each alliance, because they can, what can be brought to our communities to the each alliance probably would be strategic also for the future and also for the success of the Safe Heart plan. Thank you.
Thank you, Carlo. I just would like to ask you to give the concluding remarks, and we have to leave the room because there is another meeting, but we took care about your lunch. So before going out, grab something, because it's not very good to decrease glycemia under a certain threshold.
Thank you, Paula. Well, as we came to the end of today's discussion, I would like sincerely thank to all of you for a valuable contribution and excellent presentation, and above all, for a great spirit of collaboration that you brought here. Really, thank you for that. And advanced imaging indeed is a cornerstone of modern medicine, which enable earlier detection and precise diagnosis and better prediction and more personalized treatment. And these obviously contribute not only to a better outcomes, but also to more resilient and more sustainable health system across the EU. And Crystal and Guy, thank you so much. I was deeply touched by your testimony, and thank you for sharing your experiences with us. They are most powerful reminder of how going an extra mile can truly save life. And when you, Crystal, said, you really, I mean, it's amazing when you said it's only took one doctor who refused to settle for 99.9% and kept looking for answers. I mean, that dedication made all the difference, isn't it? I'm almost speechless. Anyway, I would like to thank once again European Society of Radiology and European Association of Nuclear Medicine for excellent, I will tell you, this is, I'm sure, the best conference I ever attended in the European Parliament. Of course, not because I'm the host, but because of your excellent organization and because of such a high level and multidisciplinary group of participants that you brought here. So the ambition that we share will only be realized if we continue to work together beyond this room, turning shared priorities into concrete action in the member states. So once again, thank you so much, and I'm looking forward for the next collaboration. Thank you. Thank you so much.